So I think we're ready to start. Sorry about Monday. I had, that new Blackboard system sends out the government email when I make an announcement. I hope that works well. I particularly feel bad if people only come to campus on that day for this class. I don't get to you. It's a regrettable inconvenience. So anyhow, you should probably tell by my voice, I'm about 80% back. Monday I was in the negative numbers, I think. And so we will pick up where I think we left off. Right? Just talk about the place of the social phobia. We were about to discuss. In fact, I introduced you to this very important concept of this inextricably linked, this symbiosis, this reciprocal inclination of panic and agoraphobia. And it's not, it's not a brain teaser. It is something that goes without saying, that if people venture out and have panic attacks, they're going to start connecting where they're going and get the idea of everything else with this very uncomfortable state of affairs. So I can't overstate the importance of remembering that. I think, well, let's just cover these again, if it is again. Forget bullet number 2. That's probably going to provide again the DSM-5, but it emphasizes that usually you have the panic attacks and then the agoraphobia develops. So if you have a panic attack first and the agoraphobia develops after that, then clearly panic disorder is established before the agoraphobia can be diagnosed. So now we talk about the panic disorder with or without agoraphobia, rather than agoraphobia with or without panic attacks. 2-to-1, 3-to-1 female-to-male ratio. This is a neurotic disorder in the definition that you become familiar with for neurosis. And as such, females continue to have a market on it. But clearly, when present, this can be a very disturbing, a very debilitating phenomenon for the individual who has it. The estimated lifetime prevalence is a wide range, so I don't know what number it gives you, and therefore I wouldn't ask you that question. And I think that's enough for you to remember. Oh, the underdiagnosed men. I may have made this point before, but clearly, I will say it again, I will repeat it, you will hear it multiple times before we finish this course, and that is this idea that is underdiagnosed in men is because of the male disposition to self-medicate, i.e., abuse alcohol. And you will recall that alcohol works on the GABA neurotransmitter systems of the brain. The very same system that is affected by the benzodiazepines. So one might argue that Budweiser is in competition with Valiant, if it were not for the fact that they recently got in trouble for watering their beers down. Don't you about that? That I think Budweiser and several of the other companies are watering their beverages down, which is a good thing in one sense. But clearly, you cannot overstate the level of use. So the being used for anxiety. anxiety and panic attacks of alcohol in place of doing something more constructive, like seeing a therapist, or something that's likely to have more long-term favorable effects. Alcohol, obviously, has all kinds. It's very effective. Make no mistake about it. Alcohol does what it does on the GABA system very effectively. But we all know that because it is so addictive, as are the benzodiazepines, it's never a long-run solution to dealing with the phenomenology that we call the distress, panic, anxiety, and even depression. All right, so here's where we're going with this. We want to be able to diagnose panic disorder. It's actually pretty simple because panic disorder is defined by the occurrence of panic attacks. So all we need to do now is to define what a panic attack is, and it's pretty straightforward. I have highlighted here for you the fact that it has an abrupt onset and peaks within 10 minutes. It peaks at 10 minutes, typically, but not always. But I'm here to tell you an important sort of take-home for you on this with regard to the academic exercise of knowing panic disorder and the personally meaningful and potentially important fact that you may utilize with a friend or relative in the midst of a panic attack is that they have a short life when they occur. That is, if they're peaking at 10 minutes, they're probably over within 20 minutes. The point being here, if you are with someone who's having a panic attack, you would only know that if they have a history of panic disorder, because you cannot assume that these symptoms are necessarily a panic attack unless that's been verified. But if indeed you are certain of that, one of the things you want to reassure your friend or relative of is that it will pass even though it feels to the individual like they're dying. It is a horrible state. If you've ever seen anyone in a real panic attack, it is very nasty. It looks often like a heart attack. And look at these symptoms. Most of them are physical symptoms. Symptoms that are indeed, by our early definition of ego dystonic, definitely ego dystonic. This is not a welcome experience. No one ever reports having had a really cool panic attack. Therefore, in that sense, you can understand why when people experience these things, they will do a lot of things to make sure they don't happen again. First and foremost, you'll find, as I pointed out at the bottom of this page, that the initial, because of the nature of the experience, the initial reaction to it is often, I am having a heart attack. Look at these symptoms: palpitation, pounding heart, tachycardia, sweating, trembling or shaking, shortness of breath, smothering. I don't have to go much farther. You can see these are classic symptoms of heart attack. But when they're occurring in a young person, as they often do in panic disorder, the likelihood of there being a heart attack is very small. But notice it did not say it's non-existent. Anyone can have a heart attack. And indeed, this is why these individuals rightfully end up in the emergency room having an MI, as the emergency personnel would call it, myocardial infarction, ruled out. A heart attack ruled out. Very easy to do. They will put on EKG electrodes, take blood, and do some analysis of blood work, and they can very quickly rule out a heart attack. So now the person goes home assured that what they just experienced was not a heart attack, and the panic disorder goes away. Right? Right. We would like it. But unfortunately, that's not the way it happens. Because another panic attack will occur. First thought in the mind of the individual is, they missed it. I need to return to the emergency room. And here's the typical scenario. Person ends up in the emergency room for a second or third time. If that person is taking proper care of herself, with regard to having established their own doctor, that family or personal physician is called. You have your patient in the emergency room, these symptoms, blah, blah, blah. He'll say or she'll say, rule out MI and tell me if I need to be in the hospital to follow up on his admission. First time, that's routine. Second time, it may still appear to be routine. So when we get to 3 or 4 visits to the ER, something else is going to happen. Normally, the primary care doctor will refer this patient to mental health professional services. And there are some primary care doctors who will take it on themselves to simply treat medically on their own, but it is not advisable, nor is it often encountered. Most often, these people will end up in a mental health professional's office, often, as I saw them, still in a state of disbelief that this isn't something connected to some physical abnormality, some event that's being missed by the medical system. And does the medical system ever miss anything? Yes. In case you didn't, I thought you all had the answer to that question. Yes, they do. It happens. It keeps lawyers off the street, so to speak. So, let's finish the rest of these symptoms. Feeling choking. Globus hystericus is an old psychiatric term for the sensation of not being able to swallow, and therefore possibly even suffocating as a result. And this is very commonly encountered not only in this special instance of a panic attack, but you will see it, and we will revisit it later when we get to the dissociative disorders, and we look at a depersonalization disorder. And you can see, we don't have to go too far into this list, and those two terms come up. Derealization, depersonalization. They are a part of another group of disorders that we will study a little bit later. But suffice it to say for now, when someone has a panic attack, they also often what comes with it is the sense of, is this really happening? I feel like I'm just playing a part of a movie here, or I feel like I'm watching myself have this panic attack. They are dissociating from the experience. Hence the terms, the realization, the personalization. So, discomfort, downward stress, dizziness, lightheadedness, fear of losing control, or going crazy. I have had more than one people sit in my office, and nearly the first word that comes out of their mouth is, "Am I going crazy? I feel like this is not me. It's descending on me. Is this the beginning? Is this the beginning of something much worse?" And that's sometimes a very serious question. Because as you will learn near the end of this course when we visit schizophrenia, it is young people, young, early 20s males, mid-20s females, who reveal schizophrenia emerging without a whole lot of other stuff going on in warning, although that's debatable, but the dysfunctionality connected to these kinds of experiences emerges in the early 20s, late teens, early 20s in young people, and one needs to address that. So a 20-year-old describing this and saying, "I feel like I'm going crazy," before you discount it, do your very thorough evaluation, and that's where, for me, MMPI was very, very useful. So this could mean all kinds of things. Most of the time, when the MI, heart attack, is ruled out, and the MMPI looks relatively clean, one can assume that this is panic disorder in the event that these events have occurred and have been persistent. And now is the question of looking for the factors that are associated with the precipitation of these panic events, panic attacks. As a footnote, I don't think you'll find this in my notes, and I'm not sure that the text makes much repeat this as well. But it has been my experience when panic disorder has been brought to my attention that there are often early childhood issues that emerge in these often young people. In fact, the oldest panic disorder individual I saw was 42 years old. I remember him very well because he was a very difficult person to get through to about the psychogenic nature of what he was experiencing. He was a very concrete kind of individual, and he was kind of seeing me because the doctor hadn't really found out what the real problem was, and he convinced him to see me in the meantime while he's searching for the obvious physical grounds for this disorder. Eventually, he was to recognize that indeed this was psychogenic and that he needed to do something about it. That is to say, do something different was required. So he and many others that I've seen reveal issues earlier on in their childhood, often early adolescence, that nag at them at some level of their existence, and often combined with what is going wrong with their life at the time. You probably heard me sort of describe this as a phenomenon in a lot of distressful symptom presentations. That is, it is not an accident that people become symptomatic in times of their lives that their lives are not going in the direction they want them to, or bad things are happening. So, when you see panic disorder, the take home on this is it is often connected to early experiences. Now, I'm not talking about necessarily the Freudian kind of early experiences. I'm talking about various traumatic experiences that can range anywhere from childhood sexual abuse in which the victim feels extraordinarily out of control, or sudden death of a parent, which was the case of this 42-year-old man, sudden death of a parent that shook him at a very formative stage of his development and got him perhaps wired for a later series of symptoms related to other things going out of control in his life. And it was the case that for this man, there were other things that he was losing control over. And these things often are very much connected. Again, the bottom line here is make sure that a very thorough investigation of history is done in all cases, but maybe I'm emphasizing, especially in the case of panic disorder. Okay, so you know what a panic attack looks like? You know it has a shelf life that's pretty small. You know that reassurance can help a person in that situation if you're convinced that it is a panic attack. And it is panic disorder when those panic attacks are occurring. And the norm is they occur unexpectedly. I was walking across campus and then it started. And once it started, it got worse the more I thought about it. It escalated. And this is a very, very common result. It is connected to agoraphobia. Agoraphobia translates roughly as the marketplace, because these panic attacks do occur often in public places where there are a lot of people like the H-E-B or the Sears or Target or mall. And indeed, why this should occur the way it does is not very easy to understand, but clearly it's a very consistently reported phenomenon among people with panic attacks, especially who will end up with panic disorder diagnosis and then develop agoraphobia around it. Persistent concern about having additional attacks is kind of like the damn if they do and damn if they don't. If they don't think about it, they get these attacks seemingly unprecipitated and as a big surprise, and if they do think about it, it's kind of like the very thing you are not wishing for is what happens. In other words, the more you think about it, the less likely you're going to be free of it. Worry about implications of tax health goes without saying. Panic attacks, feel like a heart attack, end of story. There is obviously significant behavioral change resulting from the attacks. There has to be, although often you'll find these people early on paralyzed, just paralyzed by the experience, not literally, but I mean paralyzed from the standpoint of mobility by the occurrence of the attack. And indeed, all of this feeds a potential agoraphobia if this goes untreated. There are rule-outs related to other mental conditions, not least of which would be schizophrenia, or perhaps even bipolar, but that is, I would say, quite rare under the circumstances. Now, what does the agoraphobia look like? Anxiety in anticipation of being in places or situations from which escape might be difficult. So, we take somebody right smack in the middle of the row up here, very unlikely. In fact, I will bet money, and I'm a betting man, I will bet money that there is not an agoraphobic in that part or that part of the room. Now, does this mean that the agoraphobics are all sitting right here? Absolutely not. But if there was an agoraphobic in this room, it would be very close to the door. That's what that door. So, the functional agoraphobic starts designing the environment in a way that allows him to escape from situations in which a panic attack might occur. Getting out of that situation often de-escalates the symptom emergence. And indeed, when that doesn't work, or at least when it has become so much a part of the person's life, often you will see a total retreat into the housebound situation in which the patient literally will not go off the front steps. I don't know if I mentioned this person earlier, but I knew a psychology major later in the recovery phase of her illness, quote unquote, who at one point was living in a trailer and had someone get into mail in the mailbox out in front to the door. She was literally incapable of getting her own mail. So housebound agoraphobic that her life was literally, it's entirely encased in this trailer. So housebound and agoraphobia, when it connects with the anticipation of panic attacks and therefore establishes the presence of a panic disorder, can indeed be a very debilitating issue. I might have mentioned this earlier when I talked about the difference between neurosis and psychosis, is that, one's more severe and one's less severe. Well, that's not always the case. Someone can have a relatively mildly psychotic condition in which they are delusional, but delusional in a highly specific way that affects very little in their life. And they may satisfy the criterion for a psychotic disorder and be relatively functional. The agoraphobic housebound is, by anyone's definition, almost completely dysfunctional, yet they are only neurotic. So this is one of those instances in which neurosis can be far more severely incapacitating than even a psychotic condition. So the good news for that agoraphobic is that they will not indeed be out of touch with the sense of the irrationality of their symptoms and therefore the amenability of their symptoms to treatment. Yes?
How do you get someone out of that?
That's a good question. You mean if they're actually housebound? Let me tell you a mistake I made. Did you talk about this earlier on? Agoraphobic that his husband came to see me And you know, think about, we've had this little discussion earlier about illness behavior, when we were talking about basketball behavior practice, right? Remember that discussion, how sometimes there's this sort of meta illness issue that people get into where the things you do can reinforce the conception of themselves as being ill and therefore needing someone else to fix them. So I had a husband with a housebound agoraphobic. One time, it's the only time I've ever done this. Talking in, coming to the house to attempt to start treatment with his wife in the home. This is a long story, I'll make it really short. It was the biggest mistake, one of the biggest mistakes I made in my clinical career. Because as I walked in the door, my message to her, and I was real reluctant about this, because this guy was a terrific salesman, and it was obvious that he felt, he felt very strongly about the need to help his wife. So, I mean, there were all kinds of admirable sorts of aspects of the situation that sort of seduced me into the proposition that this is a good idea, and it was a disastrous idea. I spent a couple hours with her in the house, and it was pretty obvious that the more I was attempting to help by using desensitization-based procedures, the more she became this passive recipient of my services to do for her what she had to do, partially at least for herself. So, what does that say about the housebound agoraphobic and the prognosis of the housebound agoraphobic? For me, disaster, because I will not. After that, I would not go to anyone's house. I never recommend going to someone's house anyhow, especially unsupervised. I'd be going alone to a house. I know Tropical Texas does this. They send their workers out to these houses alone, and it scares the hell out of me when I think about former students going out doing that kind of thing. It's a bad idea across the board because of the message to the patient more than anything else. Now, so to follow that, because that leaves a big gaping hole here. Now, what do? Leave these people at home for the rest of their lives? Agoraphobia is one that is a condition like any anxiety condition that waxes and wanes. Where I should have been was to say to him, she is going to have a good day soon. Encourage that to her, and as soon as she has that good day, bring her to the office and we'll get started. And indeed, that does happen. The other housebound agoraphobic that I just described, psychology major, ultimately worked out herself. So she recognized she had to do something, and in fact got out of the home and went no more than just class, and ended up choosing psychology and improved as she tried to do more for herself, and then engaged in therapy with me when I would say she was about already 20 to 25% recovered. And in fact, because she was a psych major, we had some very, very intense intellectual discussions about the advantages of this gradual desensitization idea, or the flooding notion of dumping somebody in deep water and forcing them to swim under the circumstance. I'll come back to that in a little bit when we talk about it in more detail. But yeah, it's not a good situation. And if you're a family member, it's a little easier to try to encourage someone out of that situation because you're not doing it as a mental health professional. But I would say be always aware that if you try to do that, it is absolutely imperative that part of that effort be clearly coming from the person in terms of making an effort to do something different than what they have been doing about it, i.e. nothing. The more we do for patients, the more we reinforce, if I can get back to the original proposition here, the more we reinforce the illness behavior conception. And it is very, very self-defeating. I think the whole mental health center system actually, the whole mental health treatment system actually does that in a way. But as long as we regard all of these things as illnesses, there's no escape from that. So that's probably more than what you wanted to hear. That case is actually a lot more complicated, but I could not have failed more miserably. I am absolutely certain I did more harm than good. I even felt, in retrospect, that I lengthened her outboundedness by doing what I did. And sometimes you learn as a therapist, you sometimes learn the hard way. I'll come back to another mistake I made when looking at social disorders. It can often be very, very illustrative. Okay, so here's the textbook on it. Combination of behavior therapy and pharmacotherapy. What kind of pharmacotherapy? Who knows? There are people who swear by the SSRIs. The only problem I have with the SSRIs is what is the underlying mechanism that's being treated? There's no connection between serotonin and the sorts of panic-related symptoms, nor are there any connections between that and agoraphobia. One has to suggest that perhaps some kind of a mood disturbance at its core, and that's why the SSRIs work. Point being, we have no evidence of any mechanism that is being specifically addressed using pharmaceutical interventions. On the other hand, often painstakingly difficult to do, but nonetheless effective, is an approach called systematic desensitization and an associated quicker approach called flooding that we'll get to in a minute. But for agoraphobia, by the way, there is a group called Therapy. I believe they're still in business. They've been around for years and years, decades to be sure. Started in, it stands for Territorial Apprehension. And it is a support group for agoraphobics. I think this is just an extraordinarily useful group because they are very well versed in systematic desensitization strategies, and add that to the support element, and it can be an extraordinarily powerful intervention for people with this disorder. As you'll also see by the way with PTSD. There is nothing more powerful for PTSD than a supportive group therapeutic environment. Okay, so we're walking here through the anxiety disorders, and now we're on OCD. We haven't addressed personality disorders. I think we're scheduled to in this segment. We just have to see what time allows with my convalescence interfering with our progress. But let me lay the groundwork for that now. OCD is an anxiety disorder. OCD is a personality disorder. They are both obsessive compulsive disorder when we're talking about the anxiety disorder, and you'll see obsessive compulsive personality disorders when we're talking about personality disorder. I will say now, I will please again when we get to that group of disorders. The primary distinction is an easy one. Is there an immediate anxiety experience that motivates the behaviors in question? If so, it is OCD. If, on the other hand, it is a perfectionistic, rule-governed obsession with order, rigidity, embedded in this personality that lives this way day in and day out, and you cannot palpate the anxiety, it is OCD. Okay? And you will eventually get a description of two cases, or one case perhaps, and have to make a differential diagnosis on whether it's OCD or LCPD. And again, you would look for the easiest way to differentiate are the specific acts being immediately served by the reduction of anxiety. All right. With that having been said, let's look at the features of OCD. Very, very interesting disorders, extraordinarily resistant to treatment. With one exception, if the person is brave enough to subject himself or herself to the treatment. For our purposes, And I want you to know this is an oversimplification. This is a survey overview course. When you get to graduate school, you get more details on it. For the moment, let's think of obsessions as thoughts. These are events that occur between the ears. Compulsions tend to be behavior. Observable, specific behaviors. Example, if I was an OCD, compulsive hand washer, first of all, I would never be doing anything like I'm doing right now, but if I did, I would immediately feel anxiety. That anxiety would mount. I would maybe even try to control the anxiety. It would get the better of me, and I would be in that bathroom right there within minutes of having done that. And I would wash my hands, and one could see the compulsion washing my hands. One might not be able to see, however, that it might, in this instance, be connected to obsessional thinking about the nature of the germs that I'm touching. So, the compulsions then tend to be those observable behavioral features or acts that are part of the syndrome, and the obsessions are the unobservable mental events that occur, often, but not always, to support the act and the behavior. All right, so simple answer: obsessions, thoughts, compulsions, behaviors. Okay? Just to look ahead. Obsessions tend to be recognized by the patient self-generated, as opposed to those things that might be occurring out of the clear blue sky that we sometimes characterize as hallucinations. That's controversial. We'll return to that later because there's recent evidence to suggest even hallucinations may be self-generated to the extent that the voices people hear are generated by themselves. Set that aside for the moment and think about the idea that while they are self-generated, they are out of control. And here we are with another neurotic behavior in which the patient understands that there's something wrong, irrational about their behavior, but they cannot control it, and their efforts to try to control it make it even more uncontrollable. So efforts to control tend to backfire and strengthen the very behavior that one is trying to control. And it makes sense, because if I resist the impulse to go to the bathroom to wash my hands, and I let time pass, what's going to happen during that time? The anxiety that was at this level will eventually be at this level. And now what I'm doing is going to wash my hands to reduce an even greater level of anxiety than would have been the case if I just did that very quickly, before the anxiety could even be observed as manifested by someone who might be in the vicinity during that particular point in time. Okay, thoughts can be compulsive, checking and counting. This is what the DSM-4 points out. It is a good point, so my point here is there are, as soon as I give you a distinction like obsessions are thoughts and compulsions are behaviors, obviously there are exceptions. All right, some other facts about OCD. I'll try to ferret out what's supposed to be important for you to remember here. There just suffice it to say that there's a high prevalence of this disorder, and it's even higher amongst college students. College students tend to be a little obsessive. And there are many of us who believe that a little bit of obsessiveness amongst college students would be appreciated. In fact, a little more obsessiveness amongst all college students would be appreciated by more professors who are trying to get you to the promised land of an education. And as you might guess, some rigidity, some structure that creates anxiety when you're not getting things done the way they need to be done, may have an obsessive or compulsive feature to it. But make no mistake about it, compulsions and obsessions become a part of OCD only when they achieve a level of dysfunctionality, because all mental disorders, as axis one entities, must, by definition, satisfy the blah, blah, blah rule. They must impact the ability to function on a day-to-day basis at home, work, and school. You see some OCD people, the most glaring examples that I saw in my clinical experience. As an example, was a guy in the VA medical system whose hands were shaved red and looked absolutely horrible because of the numbers of times he would wash his hands during the day. Interestingly enough, biology majors, I'm sure, will verify here that under those circumstances, this man is even more vulnerable to infestation by bacteria because he's removed all the protective oils from the skin that also serve as a shield from the kinds of things that are trying to penetrate our bodies and ultimately bring us to a state of illness. But you see, when the habit gets so bad, and this is a testament to how powerful anxiety is as a motivator, these kinds of considerations are not even entering the picture. The behavior is now occurring and becomes, as we sometimes call it, functionally autonomous. It may no longer be the rationality of the individual that they're removing germs. It is simply what is done under those circumstances, much like ask someone who smoked cigarettes for 5 years why they're lighting that cigarette up at that moment. There probably won't be a good explanation. Now, you might get them at a time when they're saying, well, I just need to relax a little bit here. But it's unlikely that out of 20 cigarettes smoked in a day, that a person at that point can identify 20 reasons why they smoke. The habit, the addiction, if you prefer, has become functionally autonomous. It no longer needs reasons. It is the reason. The smoking is the reason for the smoker. Okay? That's the way OCD becomes as well. So frequently reinforced by the reduction of anxiety that now simply engaging in the behavior has its own merits, if you will, for the integrity, the psychological integrity of the individual. All right. High prevalence amongst college students, probably more transient in college students than in other populations. Far more prevalent than taught 20 to 30 years ago. Primary care doctors are reporting seeing this far more frequently these days than before. Whether or not they're just looking for it more or it's occurring more, nobody really knows. 10% of psychiatric outpatients is one report. I'm not going to ask you if the fourth most common mental disorder after COVID is substance abuse and depression, but I think that is interesting. Only slightly more representation by females. So this is not one where the market is completely controlled by females, 2-to-1, 3-to-1. Slight more representation amongst females, just perhaps a stronger non-gender-based genetic loading. And when that hasn't been said, all of the problems with concluding that something is necessarily genetic, when in fact, often the modeling effect of a parent, or even both parents, has this powerful acquisitional effect in children. Most have obsessions and compulsions together for reasons that are easy to understand. Here's the best question way to ask, because it's kind of inexplicable if you look at it. Most common obsession is contamination and then doubt. The most common compulsion is checking. I've never understood why this is the case. You see it more than one textbook, including yours. Because if contamination is the most common obsession, then shouldn't washing be the most common compulsion? Well, you will remember on the test, won't you, that inexplicable lack of connection is just part of what we know about the epidemiology of this disorder. Contamination, number one obsession, checking, number one compulsion. And the checking, of course, is we talk about checking the door lock, I guess. What's the most common thing now? We don't have natural gas here, right, in the valley? Or do we? I don't think we do, but anyhow. Back in the day, when we had natural gas lanes, we all had what's called a pilot light. And now that the pilot light is burned out. that's why they put this horrible smell into natural gas, because as soon as you smell that, you go back there with a match and light it, because otherwise you get gas. So, obviously a lot of people got concerned. The pilot light was off, was the range all off, and people would be developing OCD habits around checking the gas range to make sure there are no leaks going on. Checking the door, especially with what has happened to movies these days, I have to believe that the checking the locks on the door has had a precipitous increase since you as a generation has become obsessed with these scary movies and these Dracula. How many more Dracula movies can be made? Obviously, at least in the short run, that can indeed affect people's checking behaviors, but it is not a disorder until it establishes itself in a way that it affects what you go to on a day-to-day basis on a work at school. I already told you about a young lady who goes to DSS, always connected to the yes, they're worried that her mother was going to die in the middle of the night under that. And she had this routine every night, 30 to 45 minutes going through the house making sure the drapes were in a certain particular way. That only she could describe to the details of which I would sort of zone out when I did it fast. It was kind of like just move through life, you know what I mean? I'm just kidding. But obviously, the level of detail that put into the arrangement of things that occur during the performance of these long rituals can be detailed and excruciating to the patient, because if they don't do it, of course, in her case, her mother would die in the middle of the night, and if they did, they paid a price for how much time it took to do so. Clearly, evidence of the fact that her ability to function on a day-to-day basis at home versus at school. I will say the treatment by response prevention and fighting for Friday, I can say the good thing we did, the success rate for OCD using flooding and response prevention is over 90%. The bad news, nobody wants to do it. I have not taught one person into completing a flooding response prevention. Let me just, before we go off the door, because we have 1 minute left, let me just give you the quick overview of what we do. Imagine that you think this desk table contaminated with germs that you just brush against it, you get so anxious that you need to wash your hands. Well, what if I sit you down in the room that you couldn't get out and make you start the session by sticking your hands into a garbage can that I have put used tissue, banana peels, rotten apples, anything else that came to my mind that would be considered germ weight, and then have you bring your hands out of that situation and not be able to get out of the room. By contract, and this is what was done in the procedure, we go into more detail on Friday, we did a signed agreement that once the treatment is started, it must be completed. I had guys committed to the hospital, ready to start, and literally within minutes of the beginning, we backed up. I did not get me signed the document, and I have not tried it since. We'll talk about more what happened in some of those circumstances. Think about that think about what the person might feel like, and we'll start with that discussion.